our topic of discussion today is early versus late FGR, fetal growth restriction. We will basically discuss upon the FIGO Delphi consensus based guideline that was evolved in 2021. That's why I started with this very first page of FIGO guideline. First we have to know the definition as well as the guideline made through the Delphi method. What is Delphi method? Any concept anyone has? Delphi method is just like a pool of certain dignitaries came into the same place. Everyone gives their own idea depending upon their huge experience as well as knowledge, and accumulating these all the knowledges and concepts, the cream concept will be taken up. This is the basic funda of Delphi consensus method, and this consensus based guideline throughout the globe it actually occurred throughout the entire globe. So this is the basically the representative of the entire globe phenomena of a very huge span of time. So the first confusion is what is SGA and what is FGR. There is a huge gray zone within this. So what is SGA? Anyone has any idea?
According to the expected.
Yes. Follow?
SGA according to expected fetal height.
According to expected fetal height. Yes. This is basically a statistical deviation from the normal. No, nothing, anything else. You all know that bell-shaped curve, which shows in the middle part the 5th to 95th percentile of the normal population. Here is a bell-shaped curve, and here is the 10th centile cutoff. That means the population within this middle part is appropriate for gestational age. We consider this, and if percentile below 10, we actually consider it is small for gestational age. That means the population, the 10th centile of the population, so there is a huge difference between centile and percentage. Centile means not 10% of the 100. That means there is a specific cutoff that is below this. How many percentage of population below the centile? That may be 20%, that may be 30%, that may be 40% also. But centile concept is like this. It's basically a statistical deviation. It's basically a statistical deviation from the normal. That is expected fetal weight or abdominal circumference below 10 percentile for gestational age is known as SGA. This is the clear-cut definition. There is no pathological variations, no anything else, any underlying causes, just a statistical variation, just a statistical deviation from the normal that is below 10 percentile is called SGA. Just clear cut this. So what is FGR? Here is the difference. FGR not only merely statistical size issue, it's all about internal pathological factors. It's basically the functional problem of unmet fetal need. Each fetus has certain genetic growth potential, we all know that, and failure to reach that factor, failure to reach that growth potential is known as FGR. It may be due to any unfavorable environmental factors, and if this failure to reach the proper growth potential occurs in early trimester, that is before 32 weeks of gestation, it's known as early onset FGR. If this failure to reach growth potential occurs after 32 weeks, it's known as late onset FGR. So this is the early onset and late onset FGR guideline based definition. Early onset FGR I've already told, below 32 weeks it's defined, and after 32 weeks if happened, then it's called late onset FGR. So what is the definition? Definition is if expected fetal weight or abdominal circumference below 3rd centile. This is the direct criteria. You can directly, jolly well, you can stamp it as early onset or late onset FGR if expected fetal weight or abdominal circumference below 3rd centile. But if not, if below 10 centile, then what will happen? This corroborates to the definition of SGA. If every less than 10 centile population is SGA, so how will you filter the FGR portion from this SGA? Yes, this is the Doppler abnormalities. What is this? It's written in the guideline. at least one of the following, that is umbilical artery PI if more than 95 percentile, or uterine artery PI more than 95 percentile. That means any one of the Doppler abnormalities along with the expected fetal weight or abdominal circumference less than 10 centile. So this is the definition of early onset FGR. And in case of late onset FGR, the same criteria, the direct criteria is expected fetal weight or AC below third centile, or at least two of the following, that is expected fetal weight or AC less than 10 centile, along with this expected fetal weight or AC crossing centiles more than 2 quartiles on growth percentile. That is the interval growth factor. I won't discuss interval growth factor today, it will be discussed next day. Along with this, the CPR if more than 5th centile, or umbilical artery PI more than 95th centile. The point to be noted over here, that this expected fetal weight or abdominal circumference if less than 10 centile, then just like early onset FGR, in case of late onset FGR there are also some sort of Doppler abnormalities. So Doppler abnormalities is basically the demarcating point or demarcating feature that demarcates from FGR and SGA. So the FGR is equivalent to SGA plus Doppler changes or very small for gestational age, that is less than 3rd percentile. So basically what happens, SGA is just a statistical variation, not anything else. Among them, if any underlying pathologic process occurs, that's why the fetus reaches to the original growth potential, that is reflected by the Doppler changes. Okay. So what is the concept? SGA basically is a larger set and FGR is subset of SGA. The population, the fetal population which is having some sort of underlying disease process, among those SGA group are called FGR. Okay. So another question, which chart to be used for diagnosing FGR or SGA? Here is a dilemma. What are these dilemma? There are 83 published growth chart and the 10 centile varied from the A growth chart to Z growth chart. There is 10 centile variation can occur, and AC ranged from 276 to 292 millimeter for a single 32 weeks measurement. Huge difference from one growth chart to another, and 345 gram difference at term. So in certain growth chart where 276 is the cutoff millimeter in written in the nomogram for single 36 weeks. So the SGA, that is 10 centile, I have already told. So this is underdiagnosed, and in case of 292 millimeter it is overdiagnosed. Okay, so this shouldn't be. So what growth chart we should take? There are several growth charts, population based customized local charts, Hadlock growth charts, Intergrowth 21 charts, WHO growth charts, and this right sided graph shows almost each and every growth chart has almost equal growth curve. So what should be the selection process? Selection of the best growth chart. It has been recommended that local or regional growth charts preferred over universal charts. Why? This picture clearly depicts this. We always appreciate this bell-shaped growth distribution because it's much more equal and reproducible over the complete and entire population. But here it is a universal growth chart. Universal growth chart, if applied in any population, it may be appropriate for one population, it may not be appropriate for one population. It may be right-sided skewed diagram in one population, it may be left-sided skewed diagram in one population. Means in this population, I have sort of an example. Here is the right-sided skewing. Right-sided skewing means actually the normal growth potential, as per the normal growth potential, if we use this growth chart in this population, from this diagram it's showing that it's underdiagnosed basically. So the recommendation is always try to use local or regional growth chart. And if we have to use universal growth chart, then we have to locally adjust the thresholds. Like in case of underdiagnosed, if tendencies are underdiagnosed, like in uh, mm, slightly more developed countries like Western countries, where the tendency of expected fetal weight at birth is much more. In these cases, the threshold should be slightly higher, like 15th percentile or 20th percentile, in between this. And in case of developing countries or underdeveloped countries, to prevent the overdiagnosis of SGA, we have to keep the threshold slightly towards the lower aspect, like 5th to 10th percentile. In this way, we can use universal charts as per the locally adjusted thresholds. Another method is USG based charts are preferred over the birth weight based charts. What is birth weight based charts? Basically, birth weight based charts are like this. In India, one birth weight based chart is there. Just for example, everywhere from India, every states, we take some examples and collect data of birth at different gestational ages. Like in some baby delivered at 28 weeks of gestation, we have to collect all the babies delivered at 28 weeks of gestation and collect all the fetal weights, all the birth weights. At 30 weeks also, at 31 weeks also. In this fashion, we have to accumulate all the babies delivered from 28 weeks, that is the viability period 28 weeks to up to 40 weeks or 41 weeks, 2 weeks, and collect all the expected, all the birth weights at this level. And we will put in the software to extrapolate in the negative direction over the fetus. We actually attributes the birth weight over the fetal weight in the extrapolated direction in the backward manner. Got it, na? That's why it's called birth weight based growth chart. But there are some sort of limitations of these birth weight based charts. What are these limitations? There are some sort of huge variations and other factors. What are those factors for? These are the baby may be low birth weight, and the cause of low birth weight may be some sort of morbidities. If we can't consider those morbidities and consider those baby as normal, then this data shouldn't be extrapolated. So these are the main limitation of birth weight based growth chart. So always try to maintain USG based charts preferred over the birth weight based charts. Okay. So here is the difference: early onset and late onset FGR. The prevalence is much more in late onset FGR, you know. Diagnosis: pathology. Pathology is severe form occurs in early onset FGR and similar to early onset preeclampsia, that is maternal vascular perfusion and strong association with preeclampsia. In case of late onset, it's milder form and less likely associated with preeclampsia. What are the characteristic features? In early onset FGR, resistance in umbilical artery, and in case of late onset FGR, it's mainly cerebral redistribution of umbilical artery and DV Doppler will be normal. Natural history is predictable sequence of Doppler changes is umbilical and DV, but in case of late onset it's less predictable. Why less predictable? I will discuss. Diagnosis is also easy for early onset and it's very difficult and challenging in case of late onset. I am coming. Management is difficult in late onset, early onset, and late onset comparatively easy. So there is a huge paradox. Diagnosis is easy in early onset, but management is difficult. And late onset, difficult diagnosis, challenging diagnosis, and there is a huge chance of sudden fetal demise. But if diagnosed, comparatively easy because already crossed or near term or crossed the term, so the sole management is just termination of pregnancy. So here is basically the etiological factors: preplacental, placental, postplacental. Nothing to understand. Preplacental are maternal age, hypoxemia, comorbidities, addiction, etc., etc. Placental factors are the most common factor, most involving factor. These are maternal vascular pathology, fetal vascular pathology, chronic placental inflammation and confined placental mosaicism. And post-placental pathologies are basically coming from some umbilical cord abnormalities and anomalies. These are the velamentous insertion, long cord, increased coil, true knot, simple umbilical artery, etc. Fetal causes are comprising of chromosomal or genetic defect, structural anomalies like gastroschisis, congenital heart disease, infections, torch infections, malaria, Zika virus, and as well as teratogens. So what are the prediction? How we will predict? Lack of gold standard single tool or prediction model for diagnosis. It's clearly written, so we have to completely solely depend upon the clinical monitoring. Relevance of combining risk factors and markers for time prediction. Early prediction prevents both short and long-term maternal and fetal neonatal risk associated with FGR significantly. So these are basically risk factors. We have to first coming to the history, proper and meticulous history taking is very important. Maternal demographics, increased age, underweight, overweight, high altitude, environmental pollution, all this goes in favor of fetal growth restriction. Some sort of medical conditions of mother, it also attributes to fetal growth restriction. These are chronic hypertension, CKD, SLE, inflammatory bowel disease. In fact, almost all the chronic diseases as well as autoimmune inflammatory diseases of mother. And obstetric history, if there is a previous history of FGR or preeclampsia, there is a 5 times rise in risk of FGR in the next or subsequent pregnancy. Some biomedical risk factors as in first trimester, decreased PAP-A, decreased PLGF, decreased SFLT1, and increased alpha fetoprotein in the second trimester, increased beta human chorionic gonadotropin in the second trimester. USG soft markers, USG factors, USG markers are of the utmost importance. These are uterine PI more than 95th centile, uterine bilateral notching, marginal or filamentous cord insertion, single umbilical artery, abnormal placental morphology, and decreased fetal growth velocity. Coming to the biochemical markers, decreased PAP-A in first trimester, along with increased AFP in second trimester. It's a very severe predictor of FGR and a very strong predictor. Another strong predictor, increased human chorionic gonadotropin more than 2.5 MON in second trimester, and or increased AFP or alpha fetoprotein in the second trimester. And some other biochemical markers are there. Decreased PLGF in first trimester. This has a correlation with adverse pregnancy outcome in preeclampsia and SGA. Increased SFLT1 also, as well as increased SFLT and PLGF ratio. It's valid for only preeclampsia, not valid for SGA. This is one important fact to know. Ultrasound markers are uterine artery malperfusion, failure of why uterine artery markers are so important, because we all know that trophoblastic invasion has immense role. We all know that there is spiraling of the uterine artery at the onset of pregnancy, and spiraling in gradually increasing, causing the proper circulation of blood, proper supply of blood from maternal to fetal circulation. This spiraling occurs due to trophoblastic cell invasion into the myometrial layer of the artery. If this trophoblastic invasion is absent or some sort of abnormal or deranged, then this muscle layer remains intact, and that's why this spiral formation is hampered and the blood flow in the fetal circulation is deranged. That's why uterine artery flow goes in some sort of abnormal way like this. These are the abnormal uterine artery waveforms with notching, diastolic notching. This is mainly due to this underlying pathologic phenomena. So that's why uterine artery malformation is very much informative and reproducing in prediction of FGR in subsequent gestational age. That is, you have already told, failure of extravenous cytotrophoblastic invasion, transformation of the spiral arteries, and development of preeclampsia and FGR. And coming to the another thing, that is abnormal placental morphology. Abnormal placental morphology is defined by placental shape change or placental texture change or abnormal placental cord insertion. Coming one by one, abnormal shape means placental thickness more than 4 cm or more than 50% of the placental length. And abnormal texture means heterogeneous, contains multiple echogenic cystic lesions or jelly-like appearance with turbulent uteroplacental flow. Placental insertion, we all know this very well. Filamentous insertion, this is the normal insertion almost in the center. This is eccentric insertion, means one side but not at margin, and marginal insertion, it is absolutely at margin. So here all the examples are written over there, shown over here. This is the mid position, that is normal placental insertion of umbilical cord. The cord insertion in placenta over here is marginal. Here is the normal, here is the eccentric. See, almost you all understand this, na? These are complications. Okay, I skip this. So prevention. Aspirin, as per trial, we all know that aspirin can prevent it if starts before 16 weeks of gestation and is given in a dose not less than 150 milligram. And LMWH, high quality trials and individual data meta-analysis shows no proven benefit. LMWH has no proven benefit. So these are the recommendation of prediction and prevention. Risk stratification of FGR in first trimester antenatal is history based. It has the strong recommendation. We have already told meticulous history taking is very much important. Biochemical markers are not recommended, only used when available as a part of prenatal genetic screening. That means when down screening, dual marker we do, that time we do PAP A, that time we do beta ECG, and if it's increase or decrease in certain pattern, then we have to take it into account, but not isolatedly. We will do biochemical markers only for HDP screening. Ultrasound markers not recommended universally. Close surveillance of fetal growth starting at 24 to 28 weeks, it's very mandatory and indicated. Smoking, alcohol, illicit drugs cessation, we all know that. Association of insufficient gestational weight gain with FGR. Association of insufficient gestational weight gain with FGR is strong strength of recommendation. And aspirin 100 to 150, basically it's 150 milligrams starting at 12 to 16 weeks may be considered in high risk of HDP or FGR group. And LMW I've already told, not recommended. So how we will detect FGR? It's basically clinical and ultrasound diagnosis. Clinical means symphysis fundal height, you all know that, just in low resource setting, just doing with a simple measuring tape and corroborating with the gestational age, providing the LMP is correct or there is any earliest week scan that can corroborate whether the LMP is agreed or not. So symphysis fundal height as a simple inexpensive tool can be used as primary screening strategy in low resource setting. Routine third trimester ultrasound for detection of FGR, no evidence. Choice of equation of for FGR to be based on validation within the local population. If not any, use Hadlock. Keep it in mind. We have already told the local charts are appreciated. If no local chart, then Hadlock should be used. Local regional chart should be preferred over the universal charts, and twin specific charts in twin gestation to avoid over-diagnosis of FGR. In twin gestation, diagnosis of FGR should include intertwin size discordance, especially in the case of monochronicity, though we won't discuss twin today. Detection of FGR by symphysis fundal height we have already discussed. And what are the Doppler changes? Doppler changes or Doppler markers we can divide into two main categories: diagnostic markers and prognostic markers. Diagnostic markers helps in differentiate SGA or early onset FGR or late onset FGR. Well, already diagnosed with diagnostic markers. Then it's time to monitor the fetus till term or whatever for a good neonatal and perinatal outcome. That's why the prognostic markers are involved over here, and it helps in deciding to deliver before 37 weeks or not. First, come to the diagnostic marker. Diagnostic markers are uterine artery PI, umbilical artery PI, middle cerebral artery PI, and cerebroplacental ratio. Coming to one by one, uterine artery, it reflects maternal supply of blood to fetus only, not the fetal component. It's only the maternal component. That's its limitation. Only maternal component, not the fetal component. And clinical application is only screening tool. It cannot be used as surveilling tool throughout the course of pregnancy. And prediction is like this: if we will find any uterine artery PI more than 95th centile, we can predict that there is a 2 times increased chance of abnormal fetal brain Doppler at term, as well as increased chance of preeclampsia. This is the only utility of uterine artery, only prediction, but no surveillance throughout the pregnancy. And this reflects the only maternal component, not the fetal component. So for fetal component, what is actually is umbilical artery. It reflects placental resistance, but there is a huge challenge. What is this challenge for umbilical artery? If placental damage more than 30%, then and then only umbilical artery changes will be there, not before that. So umbilical artery changes easily found in early onset FGR, where placental damage already occurs after more than 30% in earlier phase of gestation. In this case also, the growth velocity, expected fetal height or abdominal circumference less than 10 percentile can be manifested much more before, and that's why it's quite obvious at diagnosis. But in case of late FGR, placental damage usually occurs less than 35% unless until it goes into the later advanced pregnancy like 34 to 35 weeks. In these cases, no umbilical artery changes even at late gestation, as well as growth may also be normal up to 32 to 34 weeks. So there is a huge chance of miss. So this is a huge challenge to diagnose late onset FGR in case of in comparison to early onset FGR. And moreover, another challenge is that course of disease progression is much more rapid in late onset FGR rather than early onset FGR. So the golden period is much more less in late onset FGR. So what are the pros and cons of umbilical artery Doppler in clinical applications? It's important tool for assessment in FGR. It fails to reflect mild placental diseases, and it's often normal in late onset FGR as we discussed. So better we should apply nomogram chart and in a continuous basis while we assess the umbilical artery Doppler throughout the pregnancy, rather than using a single value over a single scan. Got everyone now? The strain has to be detected. This trend in, if we do the umbilical artery at 27 weeks of gestation, we have to we have to check the what is the umbilical artery PI. Then we have to do in another 30 weeks to 32 weeks, then umbilical artery PI, then at around term, that is around 36 weeks, the umbilical artery PI. And if we will trace the trend, then we can understand whether the PI is gradually increasing, decreasing, or in the same trend. So this is very important. Rather than an absolute umbilical artery resistance or umbilical artery PI without any nomogram charts on a single scan, this is not reproducible. This is not has any conclusion. So coming to the middle cerebral.
Abnormal trend? What is supposedly abnormal trend? If it is falling down, the PI.
No, gradually increasing PI.
Pulsatility, umbilical artery pulsatility, right? So means how? What do you define as an abnormal trend? I'm saying.
No, there is no such definition. We have to check whether it's increasing or or into the flat line. This is important.
Ideally is flat line.
Ideally flat line. As per gestational age, that's why if we consider that there's an absolute value, then it's missed, because it's the absolute value is gradually changing from gestation to gestation, na?
If this is increasing trend, that means maybe pathological.
Yes.
Decreasing trend. It is decreasing trend.
Now PI increasing trend.
PI.
Middle cerebral artery. It's also a fetal reflector. It's not a placental reflector, it's a direct fetal reflector. That's why it reflects the fetal hypoxia directly. And centralization and brain sparing effect is immensely helpful tool to detect FGR much earlier than umbilical artery. We all know that. And here also we have to follow the trend in nomogram chart. So another important marker another important diagnostic marker is cerebroplacental ratio. This is basically the ratio of PI of MCA and PI of umbilical artery. So it's more sensitive than MCA, but it's less specific than MCA. Important to detect FGR early, and it should be also followed in trend. It should be also be followed in the trend of in nomogram and chart, just like umbilical artery or MCA. What are the clinical applications of MCA or CPR? It reflects fetal hypoxia, but it reaches nadir before critical hypoxia. Before reaches the critical hypoxia, it goes in the maximally downward state. So from there, no more detection of any deterioration can't be there from MCA or CPR. That is the most important limitation of MCA or CPR. It does not correlate any fetal acidemia. That is again deteriorating, much more deteriorating stage of after critical hypoxia. So it can't detect it by MCA or CPR. And the less than fifth centile indicates chronic hypoxia.